today our talking about plaque incision and grafting surgery for Peyronie disease. So our learning objective are to provide overview of the penile curvature surgical treatment, talking about plication versus plaque incision and graft surgery, the evolution and the history of the surgical techniques, to describe different incision approaches and different graft types used, and then discuss long-term outcomes of this surgical treatment. The prevalence of Peyronie disease has been reported up to 9% in the general population. Without treatments, curvature is expected to improve in up to 13% of the patient, stabilize in 50 to 70%, and worsen in 30 to 50% of cases. The severity of the penile curvature is the main limiting factor for penetrative intercourse and for sexual function. Therefore, the goal of the treatment is to alter the shape and the curve of the penis to gain sexual function. Here is the Canadian guideline algorithm for Peyronie disease treatment. So we can see the plication surgery is indicated for simple deformity and good penile length. On the other hand, the grafting surgery is indicated for patients with maintained erectile function and have severe penile length loss, or complex curvature, or curvature more than 60 degrees, or other penile deformities like hourglass deformity and indentation. So the plication surgery, there are multiple surgical plication techniques have been offered for Peyronie disease. And the concept of this type of surgery, it is simply a tunical shortening procedures, which is aimed to shorten the longer, the convex side of the tunica albuginea to match the length of the shorter side, which is the concave side. And the pros of this technique, that's shorter surgical time, good cosmetic outcomes, minimal effect on rigidity, and it is considered to be a simple and safe surgery, and it is a very effective straining surgical treatment. Nisbet is the first surgeon that reported this technique in 1965. The Nisbet procedure employs a transverse, a elliptical incision of the tunica albuginea, which is done on the contralateral side of the curvature. Then the defect is closed transversely with permanent sutures, as we see here. In 1990, Yahya introduced a multiple variation on Nisbet procedures, and his approach is that employ a full thickness vertical incision contralateral to the area of the greatest curvature, and it is closed transversely without removal of the tunica albuginea. So in this approach, several authors have suggested this that has a lower risk for penile shortening. Then the 16-dot procedure that has been introduced, and the concept of this technique described first in 1985, and the procedures that employ the dot procedures employ no incisions, and the tunica albuginea is plicated with permanent suture using extended Lambert type sutures. This type of surgery become a popular variation of the tunical shortening procedures. In the Kyle knot plication, the sutures are placed in the uninverted matrix fashion. So each corrective sutures span 15 to 20 millimeters and correct about 5 degrees. The main advantages of this technique is reducing patient discomfort by making the sutures less palpable by puring the knots in the shallow trough of the tunica. So the interesting question is, can plication surgery be offered for complex penile deformity or curvature more than 60 degrees? Starting from this study, Hudak and his colleague from the University of Texas Southwestern Medical Center, they report plication surgery was performed in 154 men during the 5-study period, 78 men had simple penile curvature with mean curvature 30 degrees. Okay, this is the group 1. And 65 had complex malformation with mean curvature 57 degrees, which is the group 2. And 11 patients underwent penile plication and prosthesis placement at the same time. So compared to the group 1, the simple one, men that in group 2 required more plication sutures, 10 versus 7, to achieve the greater degree of the curvature. Okay, the results were no difference in measured stretched penile length were noted between the two groups. Therefore, their conclusion was penile plication is safe, effective method to correct a wide variety of Peyronie disease malformation and can be safely combined with implants. Here is another multi-center study from Italy, shows that a large volume of patients, which is total of 89 patients, underwent only penile plication surgery for Peyronie disease between the years of 1990 and 2012. 41 patients had curvature more than 60 degrees. They are followed up for the correction of the curvature, any penile shortening, and sexual function and complication. And the mean follow-up, that period was 103 months, and the results show complete correct of the curvature was obtained in 91% of the patients. So, and only 7 patients had residual curvature, which in any case did not impair sexual intercourse. The shortening of the penis was between 1.5 centimeters and 3 centimeters, which is occurred in the 20 patients. And their conclusion was, it is the procedure that can be applied to any type of the curvature. And any reduction in the length of the penis as a result of the surgery does not lead to difficulties in the sexual intercourse. This is an additional study that examined the outcomes for penile plication surgery for complex curvature in Peyronie disease. 102 patients followed up at the median of 59 months since surgery between the 2009 and 2015. Patients that were equally distributed in 2 groups, the severe groups, those that they have the curvature more than 60 degrees, or other deformities like hourglass or indentation deformities, and mild moderate groups. The mean degree of the curvature in the severe groups was 70 degrees, and the mean curvature in the mild moderate groups was 37 degrees. The results show correction of the penile curvature was achieved in nearly all the patients. And both groups reported improvement of the penile curvature with the same percentage, which is 74%. The subjective penile shortening also similar in both groups. So plication surgery is generally well-tolerated surgery. Plication can be effective even among cases where penile curvature more than 60 degrees and typically do not lead to difficulties in the sexual intercourse. For patients with good erectile function wishing to maintain penile length may consider plaque incision and grafting surgery. Okay. Talking about the history and evolution of the plaque incision and the grafting, or plaque excision and the grafting, it is started by 1943, by Oswald, at which time, 7 cases treated by plaque excision. In 1946, additional 20 cases were reported and modification of the original operation was described. The use of the fat to secure homeostasis and repair the defect after the removal of the fibrotic tissues. Then, in 1974, Devin and his colleague reported 9 cases of Peyronie disease who are not responded to the conservative treatment, and they treated for the first time by plaque excision and dermal grafting, which was harvested from the abdomen. Dyking and his colleague from the Northwestern University Medical School showed full excision technique have demonstrated poor outcomes, and therefore full excision technique largely have been abandoned over the years, and incision approach have been induced instead of the excision approach. And the reason behind this shift was the fully stabilized plaque has no further risk of recurrence over the full excision. and minimize the extent of the plaque excision, reduce the risk of post-operative erectile dysfunction, as therefore is the direct correlation between the size of the tunical defect and the increased risk of the erectile dysfunction post-operatively. So the technique of the plaque incision and grafting surgery start by degloving, the penis after the circumcision, incision. Then full erection is indicated to determine the point of the maximum curvature. Then two paraurethral incisions are made to dissect the neurovascular bundle. Pars fascia and the neurovascular bundle are dissected as shown here. And then new that erection is induced, and maintained. Two penile axes line are drawn on the proximal and the distal segments of the penis. Then two circumferential line perpendicular to the penile axis are drawn, and the difference between the long and the short sides of the penis is the width of the graft, and the length of the graft is equivalent to the distance between the two paraurethral incisions. Then an incision made forked at the end of the tunica albuginea, producing rectangular defect, and 5 millimeter dissection is made underneath the 4 defect edges and to facilitating the graft suturing. In case of the ventral curvature, the technique is similar to the dorsal, but instead of the neurovascular bundle dissection, the urethra is dissected from the bed, from its bed, and the fork of the transverse incision is made in the dorsal region near the intercavernosal septum. And in the case of the lateral curvature, the technique is also similar, but in order to avoid triangular defect, which would make the grafting procedure more difficult, as we see here, a trapezoidal defect is created by adding 5 millimeter to 1 centimeters to the curvature side of the penis. So the technique for plaque incision have involved numerous different approaches, starting from the multiple transverse incision resulting in the rhomboid defects. Later, bifurcating Y-shaped tails were added to the ends of the transverse incision, producing double Y incision. And the later technique, these tails were extended perpendicularly, producing H incision type. Okay, now talking about the graft materials. Graft materials are classified as autograft, taken from the individual themselves, or allograft of a human origin, or xenograft from different animal species, or synthetic graft. There is ongoing debate regarding the best available graft choice. Although the ideal version should be readily available, cheap, resistant to the infection, and minimize loss of erectile function and contracture, and should not promote any significant inflammatory reaction. The synthetic graft have generally been abandoned due to the high risk of infection, inflammatory response, fibrosis, allergic reaction, and eventually contracture. The dermis graft was one of the first graft used, and the original technique described by Devin in the 1974. The dermis is harvested from the lower part of the abdomen, then layered skin, that is removed and cut the underlying epidermis into the layers of 1 millimeter thick. The dermis has been extensively used and is the most extensive published to date. However, it has been reported dermis graft encourage post-operative erectile dysfunction due to the lack of adaptability. Because of this, together with the fact that the surgeon had to leave a scar when harvesting the material, the use of the dermis graft has declined, and they have not been used to any great extent in the last few years. Tunica vaginalis first time description was in 1980. That historically it is considered the third tissue to be used after the fat and the dermis patches. The pros: it is cheap, it is easy to obtain, especially by urologists, and low risk of infection. It is recommended when accessing Peyronie disease plaque via mid-ventral incisions. And due to the recommendation to use the tunica vaginalis graft with vascular flap, this can complicate their application, especially in the dorsal plaque. The fascia, could be temporalis fascia or fascia lata, can be used. In 2006, the Calci from USLS UK reported 14 patients with Peyronie disease that they have penile deformity corrected by plaque incision and fascia that treated by tutoplast. And the results show that 13 out of 14 means the overall satisfaction rate was excellent or satisfactory. The vein graft have muscular covering and elastic fibers that help to improve their adaptability. And the endothelium coating is more physiological in contact with the cavernosal tissues. The cons, it is additional surgical incision needed and graft harvesting. So this can be associated with pain, abnormal healing, scars, hypoesthesia, lymphoedema, and prolonged lymphatic loss. And one of the most important, that making the surgery time, or the surgery duration much more longer, prolonged surgical time. Pericardium, either bovine or human pericardium, origin, treated by tutoplast. And this is an acellular matrix composed of collagen that promotes cellular migration of and the replacement by tissue with similar characteristic to the albuginia. They have, in theory, very good traction resistance and adaptability and good host tolerance. The first series of the 11 patient was treated by pericardium graft, published in 2000, and the curvature was corrected in all cases without observing problems of patch tolerability or infection. And giving their use in many other surgical procedures and widely availability at almost any centers, they have, therefore, been increasingly used in the recent years. The tachoseals, the fibrin sealant patch, which is consist of human fibrinogen and human thrombin coated into the equine collagen sponge. The first time that used was in 2002 because it is patch fibrin coating does not need to be sutured, and thereby reducing the surgery time. So it is important to notice, the immediate assessment of the residual curvature of this graft is compromised because instilling saline after the procedure could cause the separation from the tunica albuginea. This is clinical observational study from Germany, which shows 70 patients with Peyronie disease treated by plaque incision and tachoseal graft, with the result of satisfactory outcomes, complete straining of the penis in 83% of the cases, and 8% of patients experience worsening of the erectile function postoperatively, and 92% of the patients were satisfied with surgical outcomes. The major advantages, decreased operative time and easy application with some additional homeostatic effect, which is provided by the tachoseal. Okay, so the question is there one graft type superior over the others? One graft review published in the American Society of the Andrology in 2017, which include 69 papers for review. The objective was to compare the straining, shortening, postoperative erectile dysfunction rate outcomes of the used different graft. So the different series published are extremely variable and heterogeneous in the term of the number of the patient included, and the patient selection, follow-up periods, and in the measurements. And given this fact, it is not possible to draw any definitive conclusion, but no graft can be identified as superior, and graft selection remains largely at the discretion of the operating surgeon. This is a review was published in the International Society for Sexual Medicine in 2019 and discussed long-term outcomes of plaque incision technique and graft surgery. It investigates the study design, procedure characteristic, patient selection, and outcomes of the penile incision and grafting technique for patients with Peyronie disease in sorry. In Peyronie disease in published studies with an inadequately large sample size. And the primary objective was to evaluate the outcomes of penile incision and grafting technique and to determine its overall success. The secondary objective was to measure satisfaction, reoperation rate, and complication. So the initial search of 2,177 articles identified 12 studies that met the inclusion criteria. 11 of them are retrospective, and only one that are prospective. And so in total, 1,065 patients underwent penile incision and grafting surgery between 1989 and 2016 from different countries: Germany, Spain, Canada, Portugal, Serbia, United Kingdom, Italy, Turkey, and United States. The patient age ranged from 17 to 82 years. The average preoperative penile curvature ranged from 52 degree to 73 degree. And complex deformity, either hourglass or indentation, was present in 10% to 32% of the patient. The plaque size was inconsistently reported. A variety of graft materials were reported, and the incision type also varied, that with double Y, that incision type more popular in the recent years, and the H incision type more popular in the earlier years. The suture materials used for the attachment of the graft also vary greatly. All studies used synthetic materials. So the result of the result in the term of erectile dysfunction show. First of all, definition of erectile dysfunction varied greatly among studies. 4 studies used the IIEF scores to assess erectile dysfunction. Other used non-IIEF subjective measures. But between 4.6% and 24% of the patient reported worse erectile function, and this were reported in 6 studies out of 12. Postoperatively, 65 to 95 of the patient were able to achieve erection unaided without using any erection medication. And this is again because it was reported only in 6 studies out of 12 studies. One interesting study, which is published in 2011 by Flores and his colleague, that revealed predictors, of 6-point reduction in the erectile function domain, and those the predictors are that preoperative curvature, more than 60 degrees, the use of double Y incision, patient age more than 55 years, and the preoperative venous leak. The straining. The definition of the successful straining was not consistent among the reviewed studies. Some studies they used the definition of the residual curvature less than 10 degrees. Other studies used the less than 15 degrees, and other used the residual curvature less than 20 degrees. One study used the definition of the lack of recurrence as successful straining. But overall, between 80% to 96% of the patient had a straight penis postoperatively, and this was reported in 4 studies, and 8 studies out of 12 studies reported that 1.7% to 78% developing recurrence. The shortening, between 5% and 40% of the patients were reported in 7 studies out of 12 studies experience shortening of the penile length, and 44 to 95% experienced no change in the penile length. 5% to 48% experienced penile lengthening. It's very important to mention that only 2 studies reported objective measurements for penile length both preoperatively and postoperatively, and both found no statistically significant difference in the length. So the satisfaction rate were very high in almost all studies, with mean satisfaction range between 88% and 92%. And this was reported in 5 studies out of 12. The rate of specific complication also vary across the studies, but overall, 2% to 22% of the patient develop complication. The most common was the edema, and then altered sensation, hematoma, and infection. The altered sensation was largely transient, with 80% to 100% of patients recovering from the sensory loss and sensory change. Okay, now I'm going to talk about the specific surgical techniques for girth and length increase in the Peyronie disease patient with resistant erectile dysfunction and concomitant prosthesis placement. This technique described by Egidio, who is a Brazilian andrologist who developed different surgical technique for girth and length increase in Peyronie disease patient with resistant ED. And his first description was in 2010, described the sliding technique and simply dividing one defect into 2, dorsal and ventral, with grafting and concomitant prosthesis placement, which is allow lengthening of each side. In 2013, he developed the MOS technique, which is the modified of the sliding technique. And the concept of the splitting is larger defect. The concept of this technique that make the larger defect into 2 smaller one, and eliminating the graft by covering the tunica defect with Plaque fascia. In 2014, he introduced MAS technique, which is multiple small tunical incision. By you doing multiple small tunical incision, and then the defect will be covered with Plaque fascia. In this type of surgical approach or surgical technique, Egidio performed 138 patients underwent MAS technique, and the penile length gain was a mean of the 3.1 centimeters. Only one patient complicated with glans ischemia. In September 2020, Egidio introduced his most evolved technique, which is the Egidio TEEP, the tunica expansion procedure. And simply stated, the TEEP strategy is nothing more than a series of multiple small staggered cut positioned on the tunica albuginea in the mesh pattern without using any grafting materials. It is important to mention this technique always involves prosthesis in placement, and this technique he published a series of 416 patients. All of them had curvature correction and penile gain of 3.3 centimeters, and the prosthesis infection was very low, 0.2% and no case of glans necrosis occurred. This is another technique which is called acoustic incisions. It is simply star incisions. It is still conceptual and experimental, which is awaiting for clinical evidence. They believe this technique successfully increase both the length and the girth, which is opening new potential solution to correct challenging cases of complex penile deformities and to restore key volume loss. Okay. So various plaque incision and grafting technique are still used. No single approach proves superior to the others. Most commonly, plaque incision is used the H and Y approaches are seen to result in similar outcomes. The choice of grafting material will remain to be dictated by the surgeon on experience, graft availability, and cost and patient preference. The most commonly used graft are bovine pericardium and tachocele. Well-designed trials needed to compare the different graft type and their surgical outcomes. Finally, the proper patient preoperative counseling with full disclosure of all the relevant details about their planned Peyronie disease procedure will always be critical for the overall success and the patient satisfaction. Thank you.